Test, test.
So, good morning, everybody. Welcome to this first meeting of the Cambridge and Peterborough Health and Wellbeing Board and Integrated Care Partnership here at New Shire Hall. My name is John O'Brien. I'm the chair of the Cambridgeshire and Peterborough Integrated Care Board, and I'm one of the co-chairs of this joint forum. And to my left, Councillor Susan van der Ven, who is also one of the co-chairs, and to my right, Councillor John Howard from Peterborough City Council, who is the other co-chair. And I'll invite them to make a couple of introductory comments in a few minutes. And we'll also ask partners around the table just to introduce themselves. I should say that this, of course, is a shared enterprise between all of the partners around the table. But the responsibility for initially convening the combined Health and Wellbeing Board Integrated Care Partnership has fallen to the ICB and the local authorities jointly. And the three of us are very determined that that should be a joint enterprise and that that should endure. So our plan is to rotate the chairing of the meetings between us. But in order to give us a little more continuity, at least in our sort of early phase of our life, we're going to do that on a sort of 2 meeting cycle. So I'm going to chair today and then in October, and then I'll pass on to Susan and John in turn as we go. And the role of vice chairs at our meetings will be assumed by the other 2 chairs that are not chairing that particular meeting. I wanted to just say a couple of things by way of broader context at the start and ask Susan and John to do likewise. But before that, just 2 things. A couple of formal housekeeping points that you're asked to note. Filming and photography is permissible at the meeting, and tweeting, but please make sure that your mobile phones are on silent or vibrate during the course of the meeting, please. Secondly, the meeting is being live streamed, and the recording will be available on the Cambridgeshire County Council website. There's no fire alarm scheduled for this morning, but if there is an alarm, we're asked to leave by the nearest exit and assemble in the car park. The closest fire escape is through the middle doors to my left, past the toilets and the kitchen. So just a couple of sort of immediate housekeeping points. Let's go around and just at least say who we are and introduce ourselves. And then after that, Susan, John and myself will just make a few introductory comments before we get cracking properly. So Susan, do you want to kick us off?
Right, hello everyone. I'm Susan van der Van. I'm a county councillor in Cambridgeshire. Did you want me to save my comments for the end? Yes, I am delighted to be here today. Thank you.
Good morning, everyone. I'm Councillor Lynn Ayres. I'm from Peterborough City Council, and I'm the Cabinet Member for Children's Services, Education, Skills, and the new university. Thank you.
Good morning, I'm Bryony Goodliff. I'm Chair of Children and Young People Committee at Cambridgeshire County Council. I'm standing in for Richard Howard, who's Chair of Adults and Health for Cambridgeshire County Council this morning.
Hello, I'm Josie Attry, Director of Public Health for both Peterborough and Cambridgeshire.
Morning, I'm Charlotte Black. I am the Executive Director for People and Communities across Cambridgeshire and Peterborough Councils.
Good morning, I'm Nicola Curley. I'm Director of Children's Services across Peterborough and Cambridgeshire Councils.
Good morning, I'm Stuart Francis, Chair of Healthwatch Cambridgeshire and Peterborough.
Good morning, I'm Julie Farrow. I'm the Chief Officer of Hunts Forum. We are the local support organisation for voluntary sector organisations, so I'm your voluntary sector rep here today.
Good morning, everyone. ACC Vicky Evans from Cambridgeshire Police. I run all operational policing. I'm here on behalf of Chief Constable Nick Dean.
Morning, everyone. Piers Ricketts, Chief Executive of the Academic Health Science Network. We support the health and care system with introducing new products and technologies.
Hello, I'm Mary Alford, Chair of Cambridgeshire Community Services NHS Trust.
Good morning, I'm Beverly Shears. I'm Vice Chair at North West Anglia Foundation Trust, and I'm representing Steve Barnett in the Trust this morning. Thank you.
Good morning, I'm Mike Moore. I'm Chair of Cambridge University Hospitals.
Good morning, I'm Jed Curran. I'm the Non-Executive Director on the Integrated Care Board.
Good morning, I'm Kit Connick. I'm Chief Officer, Strategy and Partnerships in the Integrated Care Board.
Morning all, my name is Liz Watts. I'm Chief Executive of South Cambridgeshire District Council, and I'm here representing 3 district councils in the South Partnership. That's South Cambs, Cambridge City and East Cambs.
Good morning, everyone. My name is Paul Mead. I'm Chief Executive at Fenland District Council and representing the North Place Partnership, and specifically Fenland District Council, Huntingdon District Council and Peterborough City Council.
Good morning, everybody. I'm Mayor Dr. Nick Johnson. I'm the Mayor for the Combined Authority of Cambridgeshire and Peterborough, but on one morning a week I also work as Children's Doctor at Hinchinbrook Hospital, part of North West Anglia NHS Trust. I'm very pleased to be here.
Hello there, I'm Jan Thomas. I'm the Chief Executive of NHS Cambridgeshire and Peterborough, the Integrated Care Board for our system. Thank you.
I'm Gemma Keats from the Integrated Care Board.
Good morning, everyone. I'm Councillor John Howard. I'm from Peterborough City Council, and I'm the Cabinet Member for Adult Social Care, Health and Public Health.
So thank you all very much indeed. You really are very welcome, and I'm delighted that we've made it to this point in our journey in terms of preparing to bring this body together. A couple of brief comments from me before I turn to Susan and to John. 2 weeks ago today, on the 1st of July, our integrated care system formally came into being. And I guess there's at least a couple of really important forums that are going to be helping lead that. The Integrated Care Board, which I'm chairing, which is responsible for commissioning and monitoring health services and promoting more integrated approaches to health and care. But that work, of course, is going to be directly influenced by the work of this joint forum starting today, the Joint Health and Wellbeing Board and Integrated Care Partnership. I think it's a really big opportunity for us to focus on those factors that contribute to people's long-term health, not just the immediate incidence of illness. It's an opportunity to focus on things that I'm sure all of us care a lot about in terms of earlier intervention and prevention, and to manage the demand for acute hospital care, to really sharpen the focus that we have on the sorts of inequalities that persist and indeed in many cases have got worse through COVID, between different groups of people in the experience they have, the outcomes they receive from, and their access to health and care. And I think also an opportunity to try and do that more closely, more locally with people, to be shaped by our engagement with patients and with service users and communities right across the patch. So we'll want to think about how we further those ambitions in the context of things that the system has already discussed about how we drive more at neighbourhood and place level across the wider Cambridgeshire and Peterborough system, but clearly that's something we can come back to. Now, of course, many of us have been working, and many of you have been working on this long before we've brought this body into being. And so some of the discussions that have taken place are reflected in today's papers, the sort of commitments that have been made to overarching ambitions and to some immediate priorities. We'll get onto those when we get to the paper. But also, I think the commitment to have, as far as is possible, these two legal bodies brought together in one place to avoid fragmentation and to get the best of what we're all collectively doing to promote the health and well-being of people across Cambridgeshire and Peterborough. So that alignment, not just in governance terms, but alignment in terms of the work we're doing, the strategies that we are required to produce, particularly in terms of an integrated care strategy and a health and well-being strategy, and making substantial progress on that together before Christmas. The means of how we do all that, the theology of it, we'll come on to in terms of the agenda. The last thing I'd just say by way of introduction, I suppose, is that I think certainly Susan, John and I are very conscious that we're getting going today. We've got some ground to clear, some governance to get through, but it's going to be really important that we find some ways of creating a really shared sense of what we're embarked on. And I think that clearly as we move forward, we're going to need to find some ways of working together which both represent the formal need to do business in settings such as this, but also to work more informally, to get to know each other better, to think about how we develop some of those themes in terms of the strategic agenda we face, and to think about different ways we might do that, and more informally and in ways that you can't easily do with 25 people around a committee table. So we, I think, want to think about how we open ourselves up to that, open ourselves up to stakeholder engagement on issues as well. And we may want to talk about how we do that in the course of today, but in particular, I think we are, certainly provisionally thinking about whether our October session is one that we could extend to make sure that we are able to have a sort of workshop style alongside any formal business that we need to transact. So I think, conscious that today we need to get started and to mark our beginning, but thinking about the ways we work going forward as well. So welcome. Let me hand to my two co-chairs just to make some introductory comments, and then we'll get going with what's our agenda. Susan.
Thank you, John. I should have said at Cambridgeshire, I'm the lead member for health and well-being, and we have a health and all policies approach in Cambridgeshire. We are absolutely passionately committed to this collaboration today and to playing our part on behalf of the person we all know out there. And in addition, the person we don't know and the person we hope will never need to seek us out in an acute situation. We are obviously very different organizations and different cultures, and it's been fascinating to get a sense of our different ways of working. And I look forward to being nudged into doing things differently myself. And it's a privilege, I just have to say, it's a privilege to be with all of you today, and also to meet those of you in person with whom I've been lucky enough to work all year long. So look forward to the next era. Thank you.
John. Thank you, Chair. Yeah, I'm fairly new to the role, so learning frantically as I go, I must say. But it's been interesting to see with the COVID pandemic how groups and organisations have sort of grown stronger by working collaboratively together, probably closer than they ever would have before. And I think that's some of the work that will be really interesting to see as we go forwards. And I think it's even in the spirit of the co-chairs. It just shows the spirit of collaboration there is, and how teamwork will be important as we all go forward collectively. So I'm really looking forward to working with everyone. Thank you.
Thanks very much, John. Anything anyone wants to say at this point before we get cracking with the main part of the agenda? Anything just in terms of introductory comments that people are burning to make? If not, we'll move on to the big room. I don't think I can see anybody signalling, but in which case let's get cracking, and I'm sure we'll pick up issues as we go. So in terms of our agenda, first item, apologies for absence. Gemma.
Apologies received from Councillor Richard Howard, Police and Crime Commissioner Darryl Preston, Managing Director of Strategic Commissioning Louis Campher, Steve Barnett from North West Anglia Foundation Trust, Julie Spence from Cambridgeshire and Peterborough Foundation Trust, Dr. James Morrow from Primary Care in the South, and Neil Moder from Primary Care in the North. Thank you.
Thanks very much, Gemma, and obviously some colleagues have already introduced themselves around the table who are representing some of those who are unable to join us today. Declarations of interest. We are assembling a register of interests that will be public, and I think people have been contacted about that. I think in terms of today, any interest that people want to declare, either pecuniary interests or non-pecuniary interest that anyone feels is relevant to the agenda that we've got today. Okay, there are none, so thank you for that. We have the minutes from the final meeting of the former Cambridgeshire and Peterborough Health and Wellbeing Board, the sort of whole system joint sub-board held on the 25th of March. clearly in many ways the business is moving on to what we now do collectively, but any comments on the accuracy of those minutes from that final meeting? In which case, are you happy to approve the minutes of that meeting on the 25th of March? Thank you. Let's get into the substance. It's the first item on the agenda is our terms of reference. So Kit Connick, who's the Director of Partnerships and Strategy at the ICB, is going to lead us into this. Kit.
Thank you, Chair. So you have received a covering paper and the draft terms of reference in the papers for today. I'll just briefly take us through high-level summary of that. So the 2022 Health and Care Act sets out the requirement that we must have an integrated care board and an integrated care partnership. Across Cambridgeshire and Peterborough, we've committed to aligning the Health and Wellbeing Board and the Integrated Care Partnership, which is why we're here today, and to stand this up from today. We recognise they are independent meetings, but they'll have shared agendas, and where necessary, we may to take separate decisions. We'd have a Part A and a Part B aspect of those meetings, but otherwise there would be a shared membership, which is set out in the draft terms of reference. So the terms of reference set out a very high level remit and scope on the understanding we made to review this over the next 6 months as we really think about the way in which we work together, the things we want to achieve collectively, and the partnership that the Chair has mentioned in his opening presentation. A couple of things just to mention regarding the draft membership that are still to be resolved and for discussion today. Currently, we have a single voluntary sector representative in Julie Farrow, and they ask us that there may be 2 representatives on that, and that there will be a second that would be for the integrated care partnership, should they need to meet separately. We understand there's ongoing discussions between Peterborough and Cambridgeshire around the health and wellbeing membership, waiting the outcome, but in the meantime, status quo, and we'll acknowledge that for a future meeting. Also discussions around the chairing of the meeting, and informal discussions outside of this have been a recommendation that there will be a rotating chair, as we say, starting with this meeting with John O'Brien to chair for the first 2 meetings, and then that would rotate between those other 2 councillors. And then for the remainder of the year would rotate that throughout that period of time. Otherwise, I would ask that in terms of the content of the terms of reference, whether there's any queries on that, and hopefully open that up for discussion.
Thanks very much, Kit. Questions, comments? Susan?
Only a housekeeping item. Kit, I've emailed you a few typos and things that I noticed. Thanks.
Thanks, Susan. We'll pick those up separately. Mike.
Sorry for waving my hand. I wasn't quite sure how I get your attention. So, can I just say many congratulations to all colleagues for having brought this alignment together. I think it's a really positive and important thing. And so, and then it's not straightforward in terms of all its constitutionality, but I just want to say thank you, because I think it's absolutely the right thing for us to be doing. The only other thing I'd say, and it's not really a terms of reference issue, but I guess one of the complexities we'll have to deal with is how does this get enveloped within broader activities of the councils in terms of economic strategy, environmental planning decisions. So I think we do need, in terms of some of the strategic aims we've got, to be very clear that this doesn't work on its own. It has to connect in with what's going on in the combined authority and economic strategy, transport strategy. So how those connections are made would be helpful, just to get a sense of what the chair's thinking is on how those connections are made with those wider environmental aspects.
Thank you, Mike. Yes, important point, and we can see it actually evident in some of the papers later on today. So actually how we bring that together with the combined authority and the mayor, and with, as you say, other local authorities, but also other agencies as well, I think is something we're going to have to make sure that we plug into. Susan, do you want to pick up on that?
Thank you. I guess there's a reason why there's a 6-month review of the terms of reference. But equally, I think certainly within Cambridgeshire, we're thinking about those questions, and the nature of our two authorities is very different. The makeup we have, in Cambridgeshire, we have our 5 districts. And so we have a sort of unique conversations and digging and exploration. And that I think is very much underway. And is really the heart of what this is all about. Thanks.
So I absolutely agree, Mike. I think we've got to make sure that we clearly can't exist in isolation. This is only going to have purpose and power if the partners around the table are connecting this to their mainstream agenda as well. So we need to, I think, map that quite clearly. And as I say, you can see that actually in some of the papers later on today about the connection with the economic agenda and the role of other partner bodies. So thank you for that. Other questions, comments on terms of reference and membership? Okay, we are asked to approve the draft terms of reference, approve the membership, and to note the chair arrangements that we've set out. Are people happy to accept all of those? Thank you very much. Thank you. So we now move on to long-term strategy, both in terms of how we're going to work, but also what the context for all of that is. Population health across Cambridgeshire and Peterborough. And Jyoti Attry is going to, I think, lead us off first in a presentation to help set the context. Jyoti.
Thank you. Can we present the presentation? I'm not sure who's doing that. Is that you, Michelle? Thank you. So what I'm going to share with you today is our COVID impact assessment. It's a requirement for the Health and Wellbeing Board to produce a joint strategic needs assessment and to produce a health and wellbeing strategy. And the health and wellbeing strategy needs to be informed by the joint strategic needs assessment. It's also a requirement for the ICP to pay heed to the JSNA in developing the health and wellbeing strategy. So this is the backdrop to the shaping of the overarching strategy that we're going to share with you a bit later and is included in your papers. The joint strategic needs assessment for the purposes of today has been, it's the work that we've done collaboratively. So the Public Health Intelligence team, the two councils business intelligence team and the CCG's intelligence team have worked collaboratively to look at the impact of COVID, and that is forming the content of our JSNA. We haven't viewed this as a one-off static piece of work. We will continue to evolve and develop this as we assess different parts of intelligence. And the latest intelligence that I've included in today is the children and young people's needs assessment. So what I'm presenting is a snapshot. There's a lot more detail behind this and you can access that online. So firstly, I'm going to reference the direct impact of COVID-19 on our population, and really to focus on the fact that it's had a disproportionate effect on different populations. There's a clear social gradient. So people living in the most deprived quintiles were more likely to have acquired COVID, more likely to have been admitted to hospital, and more likely to have died because of COVID. And we think that the main reason for that is that they were more likely to be exposed through work. There's also an ethnic dimension, with some ethnic groups being more likely to both acquire and die from COVID. There's a gender difference as well, with women being more likely to have acquired COVID, only a small difference, not a major difference. And at the time this piece of work was done, there was an age difference in terms of acquiring COVID, with over 85s most likely through care homes being exposed, the working age population, and less acquisition in school age population. Of course, that has changed since then, and there has been many school-based outbreaks. COVID has also had indirect consequences, both through impact on the health service, for example, but also pandemic control measures have had an impact on exposing and exacerbating inequalities. There's been an increase in people living in poverty, and I'll show you the graphs that back that up in a minute. There have been, that has an impact most immediately on health outcomes, but also cumulative over the life course. There's definitely been an impact on the mental health of our population, and particularly in children and young people. Obesity has risen, and of course there's been pressures on the health service. So this is showing the claiming of universal credit, and you can see a steep increase in spring of 2020 associated with COVID control measures. That has started to slow down a bit towards the end of this period shown in the graph, which is June 2021. However, what we've got now is clearly the cost of living crisis impacting on people's ability to afford a good standard of living, and inflationary pressures. So that may not impact on claiming for universal credit because that's based on income. We've also seen a sharp increase in the number of people claiming free school meals, as you can see in this graph, both in Peterborough, and actually a more steep increase in Cambridgeshire. And in Cambridgeshire, that equates to an increase of more than 5,000 pupils now claiming free school meals. And in Peterborough, that's just under 3,000. So quite a stark graph here to share with you, which is, sorry, on to the next one, please. Which is showing the increase in obesity in our school-age population. So this is reception. We routinely measure children at reception, and we measure them again at year 6. And rates of obesity were pretty high pre-pandemic, and this shows quite an alarming, a rate of increase that we've never seen before. And of course, that will have, if it's not addressed, a long-standing impact on the health of those children through their life course. And again, we've seen an increase in obesity in the year 6 population too. And of course, that increase has been much more steep in the most deprived quintiles, as shown in this graph. We've also seen pandemic measures impact on children's learning ability, and there's been a loss of learning. I think I've missed a graph. Loss of learning of about a month in both our primary school and secondary school population. This is showing loss of reading ability, and that's about a month. There was some recouping of that as children returned to school. It was much darker during the pandemic control measures when children were at home. This is showing that difference has an inequality. So that loss of learning has an inequality element, both at an individual level. So those who were entitled to free school meals had a greater loss of learning, and also across the geographical distribution. So the IDACI is the Income Deprivation Affecting Children Index. So it's a geographical measure. And you can see that as the scores increase, so the more deprived children are, there's also a starker increase in loss of learning, so both an individual and geographical impact. This is showing data from our health-related behaviours survey, which was last conducted in 2018 and then repeated in 2021. So this is showing a comparison between 18 and 21. There's some good news and some bad news here. So resilience measures have clearly reduced. So the black line is 2021, the grey line is 2018. And poverty has increased. So increase in free school meals, as I've shared with you, and an increase in the number of people who haven't had breakfast before the start of the school day. A mixed picture in terms of well-being, with more children being afraid that they will be engaged in, that they have been engaged in an adult argument at home, and afraid of bullying at school, but increased good life satisfaction. Also a mixed picture in terms of health-related behaviours, with some improvements in risk-taking behaviour in terms of sex, reduced smoking and reduced alcohol and drug exposure, and increased number of people having eaten 5 fruit and veg a day on the day before the survey was conducted. But a decrease in good sleep and feeling that they're in charge of their health. Could I move on to the next one, please? So the pandemic has exposed existing inequalities and exacerbated those, and I've shared some of the data with you on that, and there'll be some more that comes. So this is showing pre-pandemic deprivation. This clearly existed well before the pandemic, and this is showing geographical variations in deprivation, with Fenland and Peterborough being much more deprived than other parts of the county. Healthy life expectancy is a really important measure because it reflects the number of years that people spend in good health, and that's important because people generally don't want to extend their life if they're in pain and discomfort. It's not a desirable outcome for most people. And it's also those years spent in poor health, so the gap between healthy life expectancy and life expectancy, that impact on health and social care demands. So it's a really important measure. And generally for Cambridgeshire, women do better than men. So we have better healthy life expectancy and compare better to the England average. But for males, we're more in line with the England average. Can I move on to the next slide, please? For Peterborough, the healthy life expectancy for women is worse than the England average, and for males, it's pretty much in line with the England average. Can I have the next slide, please? Life expectancy has been slowing over the last decade, and actually for 2020, probably as a result of the impact of COVID, we actually saw a decline in life expectancy for both males and females. Can I move on to the next slide, please? Preventable mortality under 75, again, is a really important measure for us. It's a strong indicator of inequality. So if people don't live to 75, that reflects inequalities in health outcomes. And we can see that here for Peterborough, preventable mortality is in line with the England average, and for Cambridgeshire, it's a little bit better. But I think the important thing to note here is the stagnation. And over the last decade, we really haven't seen much of a change in that measure. And these are preventable causes. There's more we could do here. So just to summarize and to try to indicate how this has affected the choice of priorities in the health and wellbeing strategy, the data that I've shared with you here has really shown that, yes, we had inequalities before the pandemic, but they've been worsened both through direct COVID impacts, as I've shared with you, but also because of indirect COVID impacts, for example, on learning and income and people's affordability to have a good standard of living. And again, that's been worsened by the current cost of living crisis and inflationary pressures. And they will have both an immediate impact on health and well-being and an accumulative impact over the life course. Preventable deaths is a strong, under 75 is a strong indicator of health inequalities, and we've seen stagnation of that particular measure. And the years spent in poor health are, as I've said, undesirable to individuals and because of their impact on health and social care demand. And we're seeing a stagnation of that measure. And children have clearly been disproportionately impacted by pandemic control measures. We've seen that impact on a loss of education, but we've also seen that impact on mental well-being and increased demand for mental health services, and in fact on behavioural risk factors and indicators of poor health such as obesity. And we have the potential to really make an impact. Measures for children are more cost effective than measures for older people, and will have an impact on those children's health over their life course. And that really is the backdrop to the selection of priorities for the health and wellbeing strategy. Thank you.
Jyoti, thank you very much. So I think consciously a piece of context setting, both for the work that has already gone on among partners to think about what the overarching ambitions and priorities might be, but also just for our collective work. Opportunity for questions to Jyoti or comments, the degree to which that resonates for partners from the work that they're doing across the piece. Julie Farrow.
Thank you, Chair. Thank you very much, Jyoti, for that very interesting report and overview. One thing that sticks out for me is, and I know that you're collecting data from places that you can get it, but there's not much data there or information about the under fives. And we know that they've been mostly adversely affected, particularly by the pandemic. The rates of children not being able to socialise, not being able to go out, and their development in the under fives actually is much poorer now than it has been for such a long time. We're experiencing it in the voluntary sector. We know that actually even when children are starting at nursery school or preschool, you know, they don't have the skills that actually their cohorts before pre-pandemic did. And I just wonder if anything can be done revolving around looking at some of the data and what actually the interventions we might think about could lead to.
Thanks, Julie. I've got a few people, Jyoti. Should we take a few and then perhaps come back to them in a group? Charlotte.
Thank you. The main point I wanted to make really is that obviously we're experiencing exactly what Jyoti's described here from a kind of service delivery perspective. So we're increasingly finding that we have quite a large number of children with very complex needs where sometimes the solution isn't completely clear, and also an increased number of children who are coming our way and also the way of the NHS in terms of special educational needs and disabilities. And I guess the thing we need to think about as a board is that these are children and families who will potentially not bounce between our services, but sometimes it'll be a little unclear, you know, is it a housing issue? Is it an educational issue? Is it a health issue? Is it a mental health issue? Is it an educational issue? Which really adds power to the argument for an ICS, because I think, you know, if things are working really well, then we'll be doing much better in terms of developing integrated pathways and solutions. And I think that's the challenge really before us, is to find different kinds of solutions going forward rather than just thinking in our separate organisational perspectives.
Thanks, Charlotte. Got quite a list building up, so let's take one more at this point, and then we'll go again. Councillor Ayres.
Sorry about that. Thank you. I think that it's terribly important for people here representing Peterborough, because much of what Jyoti has said reflects on inequalities disproportionately for the deprived people. And we do have a lot of areas in Peterborough that are deprived, as indeed does Fenland. I'm very aware. And other places there are, of course, but we have a particular need in Peterborough. And I just thought I would say how very important this whole session, this whole idea of working together is for us in the north of the county. And I wonder whether there is any, I would like to ask Jyoti if there is any information about these preventable deaths, which worried me quite a lot for the women of Peterborough, of course, being one myself, and whether ethnicity had any impact at all there, because we do have a large ethnic community in Peterborough, and always have had, I might add. So I would like to know that ultimately, but I think the working together to achieve this in the county is hugely important.
Absolutely. Thank you. Jyoti, do you want to pick a few of those up, then I'll come to the next set? Thank you.
Yes. So under fives is a really important issue. And the thing that I didn't share with you because the data didn't really lend itself to it is the fact that workforce issues are also compounding all of our problems. And we have a particular workforce issue with our health visiting service. There are a number of vacant posts and they are trying to recoup the underactivity of the last 2 years. One of the things that we're asking them to do is to make sure they see children at 2.5 years so that we can get a good measure of children's development at that stage. And then that gives us a baseline on which to build. So what is the status of development of our children at 2.5 years? And then how can we work together to improve that? School readiness is also, as you'll hear in a bit in the next presentation, one of the measures that we've chosen as a priority for the health and wellbeing strategy. So it's something that we do want to work with our providers on improving, firstly, ascertainment, and that's important for identification, because if we don't see every child, we can't identify those who are in need, and then onward referral to services that could be of benefit to them. In terms of inequalities, yes, and again, I think that you will see from the next presentation that our strategy is very much an inequalities strategy. It's the thing that's driving everything that we've chosen as a priority. And yes, there is an ethnic dimension to preventable mortality. Particularly Asians are more likely to get diabetes and heart disease earlier than the indigenous white population, and therefore are at risk of preventable mortality. Thank you.
Thanks, Jyoti. So I've got 6 people signalling, so let's take 3 and then see how we get on. Mary Elford. Mary.
Thank you, Jyoti. And firstly, just to endorse the comments that Julie and Charlotte just made about the stark impact of COVID on our young people really comes through very strongly. And I agree that focusing on the under fives is vital, and we can't take can't be serious about population health, I think, unless we really do focus on under fives as a core part of our strategy. I guess the other thing I'd add is our ambition to have the children and young people's collaborative, I think, really underlines the importance of it, how important we're taking this. And I think our ambition to do something really different in terms of joined up working for our children and young people, it really comes through very clearly from the approach we're taking as an ICS. So I feel we've got good foundations in place to respond to some of the challenges that Jyoti has set out there. My question is actually about people with disabilities, particularly people with learning disabilities. I know nationally the impact of COVID on those groups has been stark, and the death rate of people with learning disabilities in particular really comes through very strongly nationally. And I just wondered if that has been a feature within our system as well.
Thanks, Mary. Come back on that point. I've got Paul, Med, and then Mike Moore. Paul.
Thank you, Chairman. Jyoti, thanks for the presentation. I think it's a really helpful insight. So I think it's recognised that often the Cambridgeshire and Peterborough averages disguise some of the local place-based realities that exist. And colleagues have obviously touched on Peterborough, Fenland as well specifically, but not exclusively. So I think my point is around local level data and how we can use that to focus our resources, commit to targeted interventions, and also a thought around how we might pursue early adopter pilots to actually convert some of the data into practical work on the ground that we can assess, what works really well, improving some of these metrics, and then perhaps look to sort of roll it out more broadly across the sub-region. So I'd welcome any thoughts you have on that.
Thanks, Paul. And Mike?
Thank you, Chair. And first of all, very much to echo what Paul's just said. I'll add to that a bit, but yes, it does resonate. So thank you, Jotty. I think it absolutely does resonate. One of the worries I've got is that in a sense we're seeing wave after wave of new crisis. So we've focused today on COVID as its impact, and of course that's had profound impacts. Some of it didn't tell us new stuff. Health inequalities are health inequalities. They have a differential impact on different communities and different groups. COVID just brought some of that out more accentuated. But we're now moving into cost of living crisis, potentially. Now, we don't know how that's going to roll out, but that too will have another profound set of impacts on people, potentially impacts on people who traditionally wouldn't come under the health and inequality extremity barriers. They're people who are not familiar with not having money to spend on heating and food. So that potentially could change some of the dynamics. So I suppose my question is, how, as a health and wellbeing board partnership, do we keep in touch with the changes of the dynamics? And here we are just about to have a little heat wave over the next few days. Again, climate change over the next 3 or 4 years is also going to be another wave of crisis. So I suppose it's just, how do we keep dynamic in our data and our thinking, which seems to be quite a challenging issue in terms of long-term population health, but how do you keep relevant to the changes? And then to echo what Paul's just said, very much, what are the levers for intervention? It seems to me that's something that we've got to be really clear about, so that we have got effective action. It's very easy to get paralysis by analysis, and actually for us, we've got to be action orientated. And how do we have the accountability to say, this program's going to happen here, that program's going to happen here, that part of the architecture is going to be responsible for this, and we're going to do stuff. So
thanks, Mike. Jodie, do you want to pick up on those three? Okay. And then I'll
yes, thank you. Learning disabilities, there has been a disproportionate impact of COVID on people with learning disabilities. So that, we're aware of that. We are actually collectively with the CCG investing quite a bit into learning disabilities. We've got an analyst and a manager coming to join us who will look at the physical health of people with learning disabilities. So I can assure you that that is work in progress. Gosh, Paul, I could write an essay about should we target by geography, or even should we target at all? And actually that will be the topic of my annual report. So that's work in progress, and it will address when it's appropriate to target and some of the pitfalls of targeting, and when it doesn't work at all. So I look forward to bringing that back to share with you and having a more in-depth discussion about that. I think adaptability, I think we can't always wait for the data because we'll always be behind. We've got to adapt and use some common sense. It's clear we've got workforce issues. It's clear we've got a cost of living crisis. And I think we just have to adapt some of our interventions to respond in a more timely fashion. Of course, we will look at the data. So we're now looking at the impact of the cost of a living crisis. But if we wait for that to come to fruition, we'll always be running behind. So, we've chosen employment and housing to address poverty through employment and housing as one of our priorities. And I think we just have to be sharp in how we do that. And I think when we first thought of it, we were thinking of people falling out of work. But what we've got now is people in work and in poverty. And I think we've just got to adapt and be agile as we develop our priorities. Thank you.
Thanks, Josie. And yeah, I think that point about being light on our feet, and it goes a bit to your earlier point about, Mike, about how we connect up with others. So how we connect up the intelligence and analysis functions across all of our agencies to make sure that we are seeing those emerging challenges is going to be really important. I've got Mayor Nick Johnson. Mayor.
Thank you. These are stark figures, and I think we all probably know about them, but it's not nice to see it in its reality. And they're probably measurements that you're used to seeing on a regular basis. I see them also from my medical background. But on the concept that if you can measure it, then you can maybe improve it. My very direct question, and this is, I think, gets to the brass tacks of why we're here, is I'm really keen to know that how often do you or your team around you get approached by constituent councils, and most importantly, the officers from constituent councils gathered here today, be they district councils, city councils, county councils. So the officers, the civil servants in those organisations approaching you and asking you about these measurements and how their policies they're developing are going to improve them.
They do, I'm pleased to say. And we recently had an event with the district council officers to share this data, to discuss how we work together to address these issues. So there are frequent questions to me about these sources of data.
And can I have just a quick follow-up?
Yes, right.
I'm interested as well. Do you know if that's a regular feature in all councils, kind of as they develop their policy, as we mark off, you know, this policy about, say, developing transport is good because it, you know, we have to think about net carbon zero effects when we're developing transport policy. Are you aware that most policies coming from wherever organisations put in public health or these sorts of outcomes into their actually direct reports?
I feel like I'm being interviewed for a job.
Sorry,
I think the answer to the second part of the question is yes. Certainly in Cambridgeshire, we've got a health in all policies approach, and we are working and building on that. Less so from the districts, but I'm sure that's something that we could work with the districts on. I'm sure they'd be amenable, and Paul's nodding at me, amenable to.
It wasn't meant to be an
That's okay.
interview, but it's just.
I've got Stuart and Vicky, but just on that specific point, Susan, did you want to come in on that particular? Oh, your way. Okay, Stuart.
Thank you, Chair. Thank you, Jyoti. Whatever we've been doing for the last 20 years in attempting to tackle health inequalities clearly hasn't worked. So the question I'm asking is, what are we going to do that's actually going to be different, that's going to address what we've seen? And yet we all know that we're working within a system that is so severely challenged at the moment and is going to, as Mike has said, I suspect is going to have even more challenges down the road, including, of course, an aging population. We know the system is financially challenged as well. So none of this is going to be easy. I recognize that. But unless there is some fundamental change, those numbers are not going to change in the next 20 years. And they're not going to change unless the money actually shifts with the need, and the money shifts into care, into community and prevention. And it's going to take some bold decisions to actually get to that place. And I don't know how you're going to do that, but I do know that that's the biggest challenge that you need to take on, because those numbers are going to get worse. They're not going to get better.
Thank you, Stuart. Vicky.
Thank you, Chair. I'll keep this brief. My first point was really to support Charlotte's observations around the impacts of this on young people and how we're seeing it come through the system. And I'm not just children's social care, but then following through into policing. And I'd say the same accounts for the mental health challenges in the community. We're seeing the acute impacts of that coming right the way through to very vulnerable people in crisis. So it's really just to show how far entrenched that is now and the impact it's having on services. Secondly, my point was very similar around prevention, that challenge of how we split our resources, our efforts. We still need to deal with the here and now, but the point is well made. If we don't get ahead of that prevention agenda, we are going to struggle to turn the tap off at the front end. And I think if you look at some of the really interesting points from Jyoti's presentation, deprivation, mental health, alcohol, they're also the same drivers for some of the other societal problems, whether that's serious violence or domestic abuse or others. And the challenge for us, I think, is making sure that we try and reduce duplication and recognise all the work that's going on in other parts of the system, not just on health inequalities, to try and maximise the effort and the short resources that we've got. And I think that's something we keep having to remind ourselves as members and think about all of the other groups we sit on, whether that's CSPs or safeguarding boards, and try and make those join-ups and get the right connections, because that's probably where our greatest ability to create capacity exists when we know that funds are so short.
Thanks, Vicky. And Susan?
Thank you, Chair. In thinking about our mapping of those with suffering disproportionate impacts, the ICS footprint is almost contiguous with the Cambridgeshire and Peterborough local authority boundary, but it isn't quite. There are anomalies. And many discussions with Health Watch about people caught out on borders of our Cambridgeshire and Peterborough boundaries, but also within. We have Peterborough and Cambridgeshire. We have different approaches to social care, some different approaches to social care. So I would like to include that kind of, I don't know what you would call it. I always call it the border country. But there are people who live in more difficult geographies for accessing services. And also, I think the discussion just now has highlighted the community. Wherever the community is, there is deprivation in every community. And hence the absolutely vital role of the voluntary sector and our community services in making that step, I think, which Stuart has challenged us on. Thanks.
Thanks, Susan. Jyoti, do you want to pick up on those final points?
Thank you. I think what we see in terms of health inequalities is a product of lots of complex factors, some of which we have control over at a local level, and they're the ones that we need to try and maximize our impact on. And they include the wider determinants, and again, that features heavily in our new strategic approach, as well as right down to access and outcomes from health treatment. So we've tried to maximize our ability to affect those through the levers that we've got locally. And again, that's why we've got a broad partnership here, including the combined authority, in recognition of the wide determinants of inequalities in health. Agree with your point about shifting. I think a couple of points were made about shifting spend downwards towards the community, more towards prevention. How we do that, I think, is the key challenge almost of what we've got to do collectively over the next 5 to 8 years. And I would argue that increasing spend in prevention won't sort the problem, because demand is higher than supply. It will reduce unmet need, and we should absolutely do it because it's desirable to our population that they don't get sick and that they don't need healthcare. But in my view, if we're going to tackle this problem, we've got to look at where we spend most of our money and where it's least effective if we're going to make that shift. Geographical access, in terms of the public health offer, we try and localize it as far as possible because we know people won't travel for our services. I will leave health and social care colleagues to comment on access to health and social care. Thank you.
Thanks, Jyoti. I think that's probably everybody who's signaled. So I guess clearly the sort of purpose of this was to sort of set a broad context and then to try and link that to the work that's already been done around emerging strategy, and some really strong themes, I think, both about that whole debate about how we shift towards prevention, notwithstanding Jyoti's points about some of the limitations about the way we sometimes see that, but the importance of how we think about our investment choices, about what's effective and less effective and how we can influence that. And secondly, I think a reinforcement of those points about how we bring a variety of agencies together, whether that's on intelligence, whether that's on action that we're undertaking in order to actually make some of this real right across the piece. So Jyoti, I think that sort of gives us a foundation for then moving on to how that relates to the strategy and the work that's gone on so far, and how we might take that forward as a board, particularly in the short term as we try and meet some of the requirements that we have. So the next item on our agenda is the approach that we're taking to that strategic development. We've got a joint paper from Jyoti and from Kit. Kit, I think you're going to kick us off.
Thank you, Chair. So if we can have the presentation uploaded, please, and I'll just set out some high-level summary from the paper that's been circulated in advance as well. So the paper sets out the broader context from Jyoti and myself regarding the health and wellbeing strategy and the integrated care strategy, and also that broader context for some of the other papers and plans that need to be submitted by health, and how they need to have due regard to one another. We've set out in the paper ownership of that, those executive leads, and some of the timescales for clarity of purpose, and some of those expectations for delivery and the broader context. So I will take comments at the end of the presentation, but what we thought would be helpful is just to run that through, given that not all partners around the table have been part of some of those discussions that have taken place over the last 9 to 12 months. So in terms of our approach, what we really want to do is pick up on what we've talked about today around that different way of working, and what we might achieve together through alignment, through integration and through partnership. And hopefully the work that Jyoti and I will set out today will demonstrate some of that we've done so far, even before the start of the integrated care system on the 1st of July. So the principles around this, around sharing our experience and our knowledge and our collective expertise to better use the resources we have together, to jointly develop those services to help improve the outcomes for our communities and in response to some of the challenges that Jyoti has mentioned already. We need to consider how we act as one public service in the broader sense, how we make sure we have a collective impact and work with our workforce and our communities to form deeper and trusting relationships and partners, so that we do speak as one voice. And ultimately to consider how what we do and how we deliver that fits together around those individuals rather than through the organisations. And in doing so, I think it picks up Mike's point about not admiring the problem, but thinking what levers do we have between us to intervene and have action and bring that real sense of clarity of purpose and how we can make a positive impact. So hopefully will be familiar to colleagues here around the shared ambition about working together for healthier futures, and those 4 strategic aims that we have set out and collectively agreed. Next slide, please. Sort of very high level approach, recognizing this you may have seen this through a slightly different format, so we're trying to be as clear and as simple as possible, recognizing this is quite a complex ask and coming from multiple aspects of different organizations. So if I work from the top of the triangle, there is one mission statement that we are all signed up to on working together for healthier futures. There are 3 overarching health and wellbeing ambitions: to have better outcomes for our children, to reduce inequalities in those preventable deaths under 75, and also increase the number of years that people live in good health. We've already signed up to and agreed informally over the past 9 months 4 system priorities that are set out around the environment to give people to be the opportunity to be as healthy as they can be, to ensure our children are ready to enter education as duly set out for the under 5s, and also to exit so they are well prepared for whatever comes in the next stage of their lives. And then to promote early intervention and reduce poverty through those broader determinants of health, through housing and other aspects. And under that, there are, for the system, 5 delivery objectives around equity, of opportunity, working with our people, our workforce, focusing on data to inform our actions, and then ensuring we have sustainability, financially, resourcing, and also environmental. And therefore, what we need to look at is how do we develop the system priority action plans? How do we co-produce this? How do we work together and consult and work with our population and our people and communities? I hand over to Jyoti just to walk through the next few slides on health and wellbeing.
I think I've pretty much covered these actually as part of my earlier presentation, so I think we can probably. You've covered the high-level objectives and the 4 priorities, haven't you? Have you covered those? No, okay. So the high-level objectives are to have better outcomes for our children, again, driven by that data that I shared with you earlier, and then to reduce inequalities in deaths under 75 as a really strong inequalities outcome, and to increase the number of years that people will spend in good health for the reasons that I described earlier in my presentation. So underpinning those, sorry, could I have the next slide, please? Underpinning those overarching priorities, overarching objectives, we've identified 4 priorities that we think will make the biggest contribution to those overarching objectives. And they are to ensure that our children are ready to enter education and leave education, that we will create an environment to give people the opportunities to be as healthy as they can be, to reduce poverty through better employment and better housing, and to promote early intervention and prevention measures to improve mental health and well-being. And I hope you can see the link between these priorities and the presentation that I gave earlier. We've also identified, for the most part, we've got one more to identify for mental health, priority leads. And this is very much a distributed leadership approach. We've got leads from across the economy working together to deliver these 4 priorities. We're now developing a program management approach to support these leads to deliver the development of these priorities. Next slide, please. I think it's back to you now, isn't it?
So Jyoti and I and wider colleagues have been thinking about the way in which we want to link those outcomes and activity, and I've had conversations with district council, chief executive colleagues, where we've started to think about how do those 4 priorities really map against the activity that colleagues in the system deliver on. And this is where you'll see that diagram on the right-hand side. We now need to think about how we move to the next stage of action, and we've considered that in terms of the phasing of approach. So the first phase will be to build on what's already in place, and we want to undertake a stock take to really understand the projects and work that's already in place across the system rather than in reinventing new piece of work. Second aspect will be to collate that information to identify where we may have gaps, and also any area where additional activity needs to be undertaken, and or review where things are not making a material impact and need to maybe either pause or stop or be delayed if we don't believe they're making a difference. And then thirdly, once we've done that gap analysis, to understand what further activity may need to take place and to fully deliver on those 4 priorities, and what resources we have in place to do that, and how we can make sure we have a clear focus. Next slide, please. So what we want to just consider is how we work with wider system partners on this, and also with the people and communities. And at the first Integrated Care Board, we brought a draft people and community strategy, which set out our system approach to engagement. And there are 4 principles that we have set out, which we'll use to guide ourselves in this work. The first is about thinking local. So where possible, how do we do this at community level as opposed to at system? And thinking about how we reset that conversation and engage differently to gather a broad range of views, so that the voice of our communities are heard and become an integral part of our new governance and approach. We know between us that navigating our various organisations and systems is very complex, so we need to keep this as simple and as straightforward as possible. We need to work together, so we shape this between us and with our population, and we need to use data to prove what we are doing is the right approach and can have the right outcomes. And so as part of that, we need to be clear with the people we're working with and our population around the range of interventions, to make sure we inform, that we listen, we discuss what is important, and where possible we co-produce and empower our communities and staff to take control. Next slide, please. And so now we need to think about how we do this, that engagement approach and the delivery timescales. We do have an expectation that the integrated care strategy will be published by December this year. At the start of this chart, you can see that we are now in July. National guidance on what is expected to be within that strategy is due to be released at the end of this month. We have had initial feedback around that, and we believe that the work we've undertaken so far is in accordance with that. And we're confident that in having an integrated health and wellbeing and integrated care strategy, we'll be able to meet both sets of the guidance around that. We've recommended that the stock take and the action plan for this will need to take place through August, and we can, Jyoti and our respective teams can support colleagues around that and how we gather that intelligence. And then we need to collate those gaps within September and October, and by November having a first draft of that strategy. Alongside this work that we need to undertake is the way in which we engage with our population around thinking about that branding wrapper, that partnership, and how we really make this a clear and engaging approach for the population we're working with, and to understand and to work with them so that they are clear about what we are setting out to do and how we will work with them. And then to make sure that is an ongoing conversation throughout this programme, and that when we come to December and we publish the strategy, it's a strategy with no surprises for everyone. So final slide, please. So at a very high level, what we've tried to set out, and we've talked to many colleagues around this table and the people within your teams, is are we clear about what good looks like for ourselves and for our population? So fundamentally, we need to build on what's already there, on the good work that's happened to date. We need to make sure that strategy and plans are meaningful and are owned by all who see and have contact with them, and they're a live document that we review ongoing, and this committee and board can really make sure that it has traction on that. There needs to be involvement of all partners, with Health Watch, the independent sector, local government, police and NHS, and that there's an equity of voice there. And then having a cohesive engagement programme that is clear for the people we work with and our workforce, so that there's understanding around what those priorities are and the objectives we're working towards. And then finally, using the intelligence and the data that Jyoti shared to the JSNA to inform our priorities and decision making, and how we make choices about what we will focus on and the impact they will make. Happy to take questions.
Thanks, Kit. Thanks, Jyoti. So I think, as both have said, this represents obviously in part the work that partners have done across the preparations for integrated care system over the last 18 months. But some of those themes also, I think, reflect some wider conversations that have gone on more broadly in terms of the reform of public services across Cambridgeshire and Peterborough. Clearly, there is a job that we have to do in the relatively short term in terms of aligning some strategic intent by the end of the year in the way that Kit's described in terms of the requirements. But obviously the way we bring that to life and the way we really develop and iterate that is going to be a longer process, and I think links to the point I made at the start that obviously as a group we need to find a way, some digestible ways of working on that together, informally as well as formally, and in different settings, to simply sort of being round the table. So clearly that's part of how we think about this development as well. But I suppose for today, it's a sort of here's a roadmap for the next 6 months, but here's how that segues into the medium and longer term. How does that feel to people? What's their views? What questions have they got about that process? So over to you. Got Mary first.
Thanks, Kit. That's very, very comprehensive statement of the ambitions for the next few months. I just want to be kind of clear on the engagement. You said that we're going to be careful not to work with what's already there. And I'd just be interested to hear a little bit more about that, because I guess the concern is there are certain groups who we are, between all of us, we're already engaging with quite a lot. I think, say, parents with children with special educational needs are probably getting an awful lot of surveys. So I think I guess what I would like to just get assurance on is that our approach will be looking to where the gaps are, because I'm sure there are other groups in our communities who we're not engaging with sufficiently. And also, I guess, a plea for perhaps some capacity building for trusts who are already engaged, but maybe could be doing a little bit better. So I think just a bit more on how that process will work and work smarter, I guess, so that we identify the gaps, but we don't over survey those who we're already engaged with, but perhaps support those of us who are doing that engagement to maybe do it a bit better and do it collectively. We've started some work with Cambridge and Peterborough Foundation Trust, for example, to ensure that we can try and bring our parent groups together. So again, you know, as providers, we can work in a more sophisticated way to engage with young people and parent groups, and just want to be sure that work isn't going to be duplicated. Thank you.
That's an important point about, as you say, building on what we've got rather than duplicating. Mary, I'll bring Kit in after we've taken a few of these. So I've got Bev and then Liz. Bev, first of all.
Thank you very much. And it's good to see this coming together in a very straightforward, direct way. My question is a build on Mary's question, really, but it was more about, we've heard this morning a lot about the inequalities and the challenges we're facing. And I suppose for me, how are we going to move engagement on so we actually engage with the people who are service users who are hard to reach? And they may not respond quite so positively to things like surveys and being asked, but how do we involve in co-create and co-production? Our trust has been doing a lot of work with Asian community and Eastern European community, and it is a challenge to build up that trust so people will speak openly and straightforwardly about some of the issues they're facing. So I suppose, how do we build that in systemically into our priorities, which are all about health inequalities, preventable deaths? Thank you.
Thanks, Bev. And I've got Liz.
Thank you, and thank you for a great presentation as usual, Kit and Jyoti. Building on the previous two speakers, but coming from an organisational perspective, what struck me most this morning is what Stuart said, which is that if we're actually going to have an impact here, we need to do something really different. And I think in local government, we are doing lots around improving health, which isn't kind of seen under the umbrella of health. And my worry about this kind of excellent proposal is that doing a stock take of what's happening in 1 month, I think is way too ambitious. And I think you will lose a lot of what is happening and lose a lot of what the opportunities are. And we will get ourselves into a strategy by December that won't have picked up how we can do things differently. And so while, as people who know me know, I'm the most impatient person in the world, I suppose I'm cautioning a little bit that if we are really going to do stuff differently, we maybe need to take a bit longer over it.
No, and I think we may have to do what we have to do for December, but I think you're absolutely right, Liz, that if it's going to be real, we've got to make sure we're not boxed in and that this group and others have got the ability to shape that. So I think that's really important. Kit, sort of a number of points on engagement. I've got sort of almost everybody wants to speak, so I'll let you just pick up those points quickly, and then we'll come back to others.
So I think the point about engagement is very well made, so thank you for that. And it's a conversation we've been having between our teams about how exactly we do that. So I'm not going to walk through that we've got exactly the plan, because we haven't. We need to give time and consideration to the experts in those comms and engagements teams to really work that through, and those leads between health and a local authority are working that up. But the principles are, we build on what's already there. We use existing governance and groups where possible, not adding in additional. We're clear about the purpose. We're clear about who and why we want to engage with. And where we know there's existing work in train, we're either through provider organisations or through those emerging places and collaboratives, we engage with them as well. So there's a slightly more detailed presentation, for example, coming to next week's system and strategy planning group to talk to some of those colleagues about how do they want to work through this, what would good look like from their perspective. I think your point absolutely is right around those hard to reach groups. If I may challenge that slightly, I think we need to challenge ourselves that actually, are they hard to reach, or have we not tried hard enough? And I think that's the point I would want to make. And we need to seek out where those communities are. And the fact that we refer to people, to groups as communities, tells me we don't know who those people are. When we start to talk about people in names and individuals, then we really know our communities. And I think that's where district council colleagues will come in terms of really knowing those individuals, those key stakeholders who are going to make that impact. And that, for me, will be a measure of our success in a year's time. And to come to your point, Liz, I think you're absolutely right. I am concerned about the expectations and timescales, as is Jyoti and other colleagues. We are required as a partnership to issue the first strategy by December. That's an expectation and national guidance. But I think that we need to recognise this is a journey and a point in time. We won't get it all right first time. And we need to consider how each year we understand what has worked, what hasn't, and be prepared to evaluate and evolve. And on that note, I think we need to recognise what's good enough for now, and that next year it won't be good enough. So I think we need to challenge ourselves around that. But I think you're right around that stock take, and we can take that back and see how we can undertake a stock take over a longer period of time while starting to draft and write as well.
Thanks. I've got John and sorry, Jodie, do you want to?
I just wanted to add a little bit to what Kit has said. I mean, the strategy at the moment, it's an overarching strategy and probably wouldn't engage most people. It's quite a high level. But one of the things that we are going to do with our comms people is to market test the wording. We recognise it's probably not wording that most people would recognise or understand. So we're going to do a bit of plain languaging the work that we've done so far. And just to pick up your point about, how do we want people to change their behaviours. So we've got to engage with the panel. We've got to understand why they do the things they do, why they don't do the things we want them to do. And actually the commercial sector is brilliant at it. So we want to learn from them and use their techniques for social good. And we have done some behavioural insights work already and use that. For example, in COVID, we did some work around why people in poor communities weren't accessing vaccination, and we found that older folks were anxious about parking and whether there'd be toilets. So that got incorporated into our materials and hopefully had a positive impact. So absolutely want to learn from people about what their motivators and barriers are. Thank you.
Just to assure people, I know we've got at least 7 people who want to come in yet, but I'll take the next 3. So John, Jed, and then Jan. John.
Thank you, Chair. Yeah, looking at it, I mean, it looks a really good strategy, and I think the priorities are absolutely right. I think the really interesting bit will be as we move on to the how. How do we deliver this? And looking at it, it's very, very complex, multi-agency, and it involves many people who don't even sit around this table. So I think it's really important for all of us as members that we take this back on a local level and share this with all the people around us so that there is that joint working. But I'm really sure with the 4 priorities that there is leads on it, and I think that will really help develop the strategy as well. So I think that's really commendable. Thank you.
Thanks, John. Jed?
Yes, thank you, John. And thank you both for the paper, which I think is really helpful, very clear, rational approach to the issue. I suppose my concern is about the emotional element of the engagement that we wish to achieve. These kind of consultations around strategies are notoriously difficult. They're a kind of powerful anesthetic for people, really, aren't they? And generally, you go around stirring up apathy. It's very hard to get people to engage with something which isn't going to impact on them for quite a long time. We tend to use very rational models and to send out documents to people which don't engage either. I was just interested to know what chance you've had to think about how you're going to inspire people to respond in a way that gives us stuff that we don't already know, really. I appreciate you've got lots of time constraints, but it'd be handy to know how you've approached that aspect.
Thanks, Jed. Jan.
So I guess there's just a couple of points leading on from what Jed says. I think we've just got to be careful not to tie ourselves in knots on the word engagement. And I think that's true because I find it really weird that I have a conversation
And then 2 seconds later, if I look at my phone, surprisingly, what I've been talking about is now adverts on my phone. Okay, you know, and I don't know. I don't know how it works. I don't think I even want to know how it works. Quite frankly, it scares me. But actually, we keep across our how we talk to people. Talk about engagement. We go and talk to user groups. We go and talk to different parts of the population. And I think if we're really going to master this, we've got to decide how brave do we want to be to really use technology, data, different ways of reaching people, not to ask their opinion, because that's lovely to know, and it is, and we should keep listening. But actually, unless we can start intervening at the point people are making decisions, and unless we can distribute those messages more effectively, we are just going to keep listening. And so I think my first challenge on this is I completely endorse this strategy, but we as a board have got to decide on where we keep talking about engagement and consultation. Actually, that's a process. An active thing we need to do is think about how brave we want to be in interacting with people as everything outside of, I would argue, lots of these domains do. So that's my first challenge, really. And that's not really to Kit and Jyoti to answer, by the way, although Kit, it could be quite fun trying to. And the second thing I'd want to say is we are doing a huge amount already. And I think we've got to be really careful with the now let's get on with it, because we are getting on with it. And actually, I think we've got to take a step back. The reason I like the fact the first thing is take a step back and quantifying the stock take is actually, I suspect we're doing things that maybe aren't helping as much as we think we are, and we've just carried on doing them, which is using resources and time and people to do. So the stock take shouldn't just be, let's celebrate what we're doing, but it should be an evaluation of, is it working and should we carry on, or should we redistribute those resources elsewhere? So, and again, we as a board are going to have to think very carefully about that, because it's not the land always of more. I think the third thing I just really wanted to make sure we were all conscious of is this strategy will be great, but it's not a document that sits on its own. And our challenge is, and it's a bit as Nick talked about earlier, which is how do we weave these through every decision that we are making, because that's the way we'll drive change. So how is every intervention we're doing with individuals or as groups or as boards serving towards these overall objectives, as well as programs of work that are solving problems? Because this is a kind of get ahead mindset to me that we're trying to get to, as much as a series of stuff to do.
Thanks, Jan. Let's just take one more in this round. Lynn.
Thank you, Chair. I think this is more of a comment and picking up on things that people have already said, but I'm absolutely delighted that children are very much in the fore of everything that we're talking about today, because as I keep on saying to people, I am not the future, they are. That is for sure. And therefore early intervention with children, to me, is hugely important. But I do think we've got to prioritise. I mean, there's so much that needs doing. If we don't prioritise right at the start, you don't get anything done if you try to do too much. But when it comes to language, I do think that matters. We've discovered that in Peterborough, trying to get to our deprived communities and people such as that, and you suddenly realise they don't understand the words that you're using, even though you do. And and acronyms are definitely out when it comes to putting a strategy forward. I think, you know, you can't use those because, I mean, I don't understand most of them. And the hard to reach communities know even less, and therefore it's very important. But when you're dealing with children as well, why not listen to children? You know, have a voice of the child somewhere. We talk about that all the time when we're doing children's services in Peterborough. So why can't we talk about that when it comes to health as well? But at the end of the day, a lot of this is all down to funding, isn't it? And it most certainly is going to be in Peterborough City Council. And that is the area that worries me. But anyway, thank you for putting children at the top, nearly at the top, if not at the top. Thank you.
Kit, Jyoti, I don't think you need to respond to everything because quite a lot of those are comments, but there are a few questions in there. So anything you want to pick up on that group, including the how we engage with people both emotionally as well as rationally.
Just want to make a couple of points actually about there's so much to do, how we're going to do it and how, what are we going to do kind of thing. And I think we've got 4 priorities, but we've got to prioritize within those priorities if we're going to do anything meaningful and show that we've made, demonstrate in a measurable way that we've made a difference. So I'd, advocate that we further prioritize even within those priorities and pick 1 or 2 things that we really want to drive forward on and can make a difference on in the next 5 to 8 years. Engagement, I think there'll be much more meaningful engagement as we get into the meat of the priorities. That's where I would see really meaningful, in-depth engagement happening. And, the emotional level, I think, is through behavioural insights. What is it that makes people do the things they do? What is it that stops them from doing the things we want them to do? And then working with them on addressing those, accentuating the motivators, addressing the barriers. And that is the only way we're going to get the kind of behavioural change that we need to get in our population.
Thank you. So I'll take the final set of signalled. I've got, first of all, Mayor Nick.
Yeah, it's a question for Kit. And in regard to if December comes along and we've got the strategy, I'm really asking as to how would you then see, by the way, I love the priorities. As far as I'm concerned as a mayor and from what I would be saying within the combined authority, we're completely signed up. But once we've got the strategy, and I appreciate there's lots of time pressures on there, how are we going to demonstrate it? And is it something where we visibly, and I'm saying this now, as a combined authority, we send out on our paperwork the 4 priorities? Because for my organisation, or for the organisers of the combined authority, it covers quite a lot of those things. But I would ask the question, maybe if it was to say with, say, the police or district councils, they may say, well, we don't always get involved in health. Would it be that every single constituent is all signed up and we're all saying these strategies, even though we're not statutorily responsible for health, everything we do is about the health of children, which goes back to the point that Lynn was making. Is that something that you see happening? Or, it's a...
So that is what I would hope. It's not for me to decide, it's the collective to agree. Yes, that is the intent and purpose we're here to do, to make that difference. I think that we need to be clear about this, why it's important about the stock take of what we're already doing. So it's how these, let's take the word strategy, is what we're doing making a difference, and are we really bought into it, and is it collectively going to really change the challenges that we've talked about? We also need to bear in mind that not only have we got the integrated care strategy, but the integrated care board needs to develop a joint forward plan that has due regard to what we're setting out in this forum. And so there'll be some very clear deliverables within that 5-year forward plan about what we're going to do that's going to make that impact. So I think the short answer is yes. How we do that, around how we publicise that, how we make sure that they are a live and living way for us to make decisions in this forum, I think we need to work through collectively.
Okay, I've got Stuart, Paul and Piers. So Stuart first.
Thank you, Chair. For too long, if I can talk about engagement, for too long, I think that all of us should accept that engagement has been a tick box exercise. I don't think it is now. There's every indication that this is going to be dealt with as something that's important. I mean, what we're looking for clearly is better productive engagement. And the only way we're going to get that is if we continue to shift the cultural dial within our system, less paternalistic, more to working in partnership, equal partners with patients and those in care to co-design services. I'm really keen that Mary's initial point is not lost. There is some really good engagement going on out there. In fact, 3/4 of probably what you need is out there. might need to be reorganized, recalibrated, promoted, invested in, and you need to add to it. But that really shouldn't be forgotten. And there's lots of good work going on with organizations and patients at the moment. Healthwatch is doing a piece of work with Adam Brooks, which is important, and it's really working. So I find myself asking the question, in terms of engagement, do we actually need to have another big conversation, or we need to have lots of productive little conversations?
Paul. Thanks, Chairman. A couple of points. So I think it's worth noting there's been some excellent work undertaken to get the strategy to this point. And I think what's really impressive is the kind of system-wide ownership that there is for the strategy and the priorities. I know a lot of work's gone on behind the scenes to get the strategy to the point it is today. My second point, it kind of links back to what Stuart said under the previous item. We have essentially seen 20 years of flatlining performance where health inequalities are concerned. And through this strategy, its interventions, how we engage going forward, how will we know that it's translating into improvement? What kind of checks and balances along the way will we have to give us that measurement, recognizing that some of these issues are pretty profound and more medium, longer term in terms of hopefully correcting them to the extent that we want to do. So I suppose it's an observation, a question about how will we know we're being successful in what we're attempting to achieve.
Yeah, thank you, Paul. Really good challenge, Piers.
Yeah, I really like this. Well done on a framework which can get so much buy-in from all the different agencies in the room. I think it's really good. Just a couple of practical thoughts which I hope are helpful. In the time available, you can never do the perfect plan, the perfect consultation, the perfect stock take. But I wonder whether to give confidence to this group and others. Every few months you can release some stories of initiatives that you've commissioned, all things indeed that you've stopped, if we're shifting priorities, that show that things are starting to happen. So I think that's really important. And also to the comment just made, you can set up some medium-term evaluations of some of the bigger initiatives that you commission at the same time as you implement the service, whether it's RAND or some of these sort of independent organizations. I think that would be helpful. And then just a couple of resources that might be available on engagement. There's the Health Foundation sponsored Innovation Hub run by Patrick Williamson at CPFT that's thinking about how we engage, so they'd be worth talking to. And I wonder whether you've made use of the work of Hilary Cottam, Radical Help, one of the architects of the Wigan deal, where real community activation, which does take it, to Stuart's point, back down to the sort of smallest community level, because we haven't got the money to do everything. And so those sorts of things, it'll be a conscious effort, but that might be worth thinking about.
Thanks very much, Piers. Really, really helpful signposting. I think there's some helpful resources. Any final comments from Jyoti or Kit in response to those, or more generally before we move on?
I pick up evaluation, you do engagement. Sorry, measurement. We are developing a set of measurable ambitions for each of the priorities. Where do we want to get to? And we've had discussion about this. We want them to be stretching but achievable. So we will set those. But I think we also have to be mindful that things could get worse before they get better because of the situation that we're in. We are also asking leads to come up with some early wins. Not all of this needs to be long-term. There are some things that we can achieve in the next year or two. So that's going to be a challenge to the leads as well. And for new things, we would absolutely want to see evaluations as part of the project. Thank you.
So I think that the only comment I'd want to make is to thank colleagues for such a really robust discussion and the offer of help and advice. And I'm just conscious that we've used the term engagement. I would never say to anyone, I'm going to engage with you. I'd say I'm going to come have a chat with you, have a conversation. So the action I'm going to take is come and have a chat and a conversation with the people around this room, because what I've heard is offers of help and support and how we do it together. And if it's okay, I'm going to take that on board and how we do this outside of a meeting in a very real way. And that's the way we need to talk to the people who live in our communities, have conversations, not engage with them.
Thanks, Kit, and thanks everybody for their contributions. I think we've marked the point about timescale. Yes, there may be some things we have to achieve by December, but clearly we're not going to do any sort of justice to the richness of the issues we've discussed by that point. So we need to leave ourselves open to both developing the strategy and our means of engaging, if I can use that term, with people. I think that on the engagement point, obviously really important about how we build on what exists, Mary's point, and making sure that we don't sort of ignore that or set up parallel streams where we can bring that together. Also, I think really important that we use the asset of the community, of the partners around the table and the insight they have into communities, whether that be local government or the voluntary and community sector in particular, that we actually use that rather than have parallel streams. And of course, that we develop a conversation with communities which actually builds on the assets and the strengths that they bring to this. And lastly, that as we develop that work over time, we collectively will want to do that in a range of different ways, as we said earlier on. So we're asked to, at this point, approve the overall approach moving into the consultation that's been discussed, and to how we'll get towards both an integrated care strategy and health and wellbeing strategy that can work with the national guidance within the time frame, but I think within the context of what we've discussed about a longer time frame for our work. Do people agree those recommendations that are in the paper? Thank you very much indeed, and thanks for the discussion. So we've got two, I think, specific items left on our agenda. The first is looking, if I just find my bit of paper, is the health and well-being, sorry, no, it's not that, sorry. Yeah, okay. This is the health at work strategy priority, which links to one of the overarching priorities that we've spoken about. And this is about reducing poverty through better employment, better housing, but also this is, as I say, is the health at work strategy element of that. Can I ask Val Thomas, who's the Deputy Director of Public Health, to introduce the report? Val.
Thank you, Chair. I'd also like to introduce Alan Dalton, who is virtually with us from the Combined Authority, and Gemma Little from Cambridgeshire City Council, who've also one of many who contributed to the strategy. As you said, it does speak to one of the priorities, but perhaps it does speak to the other priorities as well, but primarily to the poverty priority. And this is why we brought it here, to seek the support of the committee, and also for ongoing consultation, or should I say chats with people. I'm going to run through a short presentation. I'm very much aware of time. It's a big strategy, and we've tried to condense it into a short presentation to pick up on the key points, and I will try and share that. Right. Sorry, my screen is not trying to get it on full screen, right? Okay. Right. I think in terms of the background of this strategy, we've had work in Cambridgeshire and Peterborough, and a lot of efforts to address the issue of work and health. But more recently, we've had some new national policy drivers which have brought a renewed focus to work and health. We still have the challenge of small to medium-sized companies, which do find this particularly challenging. But perhaps it's the COVID-19 pandemic that really highlighted issues, particularly the poor wages and insecure contracts, which really affected how COVID impacted on themselves, their families and communities. But it was, we've had a sort of catalyst in the sense that back last year, in fact, the Work and Health Unit, which is a joint Department of Work and Pensions and DHSC unit based now at the Office of Health Improvement for Disparities, approached us as a system to see if we would like to pilot the development of a work and health strategy. And the outcome of this was a partnership between the Work and Health Unit and the Cambridgeshire and Peterborough system. And in terms of what that meant was that as a group that have been working on this, and this, in many ways, this is a test case of how the system came together. It very much has been the integrated care system, KITS team, the combined authority, Alan, who will speak later, and then the district councils as well, and obviously the two Cambridgeshire and Peterborough councils. And more recently, we're joined by the workforce programme in the ICS. And we've been meeting since since October on a very regular basis, and have worked very collaboratively to put this together. Very briefly, this is our theory of change, which we worked through at the starting point. What's the problem? What are the barriers? What are our priorities? What are our desired outputs? And what are the impacts we would want? This we shared with other systems that was facilitated by the Work and Health Unit as a template to work with within their own systems. Again, very much in the spirit of this is a system-wide issue, it's a collaborative issue, and we've gone through various phases. The first, I'm very wary of the word engagement at the moment, but we did go through engaging the system and building our local picture. We then worked very much with employers, and I'll come back to this. And consequently, we now have this draft strategy, which we've brought here today. And I'll come back to the next phases. So why do we need a strategy? I think there's very clear evidence that work has a very important role in health. Obviously, income and the links between income and health, but also it gives a sense of identity, it gives a sense of place and a sense of belonging, and contributes obviously to economic growth and prosperity. And this infographic captures those synergies, how good worker health is very much linked to productivity, it's linked to business, overall development and social well-being and health, and back into good worker health. And the obvious factor in there, increased prosperity, employer resources to support good worker health. Again, some of the just facts and figures which just highlights there the impact of poor health on the system. So why at this moment in time the strategy is so important? I think the presentations earlier drew attention to healthy life expectancy. In our area, in some of our most deprived areas, some of that healthy life expectancy is very, very premature and is very much falls in within the working age. We have different types of employment. We have large employers which have large workforces, often on low wages and perhaps insecure contracts. Again, as I mentioned earlier, very much brought into high relief during COVID. There's the other factor around our workforce. So it's our working age population is growing more slowly than the national average. Something which resonates perhaps with everyone is the workforce shortage. National vacancies, the most recent ONS survey says we are at record levels. And although we have now got more people, payrolled employees in the system than there were in March, but the vacancies continue to rise. We have substantial numbers reported to be long-term sick. And also we're getting that evidence which very much appeared as a consequence of COVID, of early retirement. And increased claims on universal credit. I think what it highlights more than anything is that our workforce is very precious and it needs to be nurtured and supported. And this is very much the basis of this strategy, is the largest proportion of our population falls within that working age, 16 to 64, 65, 66. And it's an opportunity to really make an impact on health. As part of the development of the strategy, we sought conversations with the Combined Authority Business Advisory Panel. We did a survey amongst employers. We had a workshop, and we also, let's say, we had some interviews, the lived experience with people who accessed the job centres and were out of work because of illness or disability. The key themes that emerged from that in terms of challenges for employers were structural issues within the workplace, lack of information for employers, and this was again very much on the small and medium-sized employers, training for human resources and occupational health, and of course resources. And again, that always comes back to the smaller employers not having resources to build this infrastructure to support their workforces. The lived experience was very poignant in many ways in some of the descriptions that we had back in terms of the challenges that people were out of work because of poor health. Things like not being able to have transport to interviews, not being able to travel to work on public transport, desperately wanting to work, but not having the flexibility within the system that would enable them to retrain. Again, another key thing was integration, and this is why I think this strategy plays so much to what we're all here for today. I think the feedback was, you know, we go to our Job Centre Plus, we go to our GP, we go to our health services. How can we join this up? How can we make it more meaningful for people and produce better outcomes? And that same thing then applying to those in employment. How can they maintain employment if they are challenged by their health or by a disability? And the greyness around what a reasonable adjustment is and how that's interpreted. And then going back to our local strategic framework, which I won't labour because I think that's been the whole point of the previous presentations. This does very much speak to that reduced poverty, but I think if you looked at the other three priorities, it would certainly speak to those as well. The long-term shared goals around better outcomes for children, preventable deaths, and healthy life expectancy. Our work and health goals again, we feel would contribute to those. They're very specific there, but certainly we've framed them in that context. So I think traditionally, when working in this area of work and health, the focus has been very much the workplace. How do we make a healthy workplace environment for workers, and how do we work with employers to do that? The scope we've broadened and looked at very much those people who sit outside of the workplace because of a health or disability. What can we do to support them into work? How can we facilitate that? But then in the workplace itself, how can we ensure that people who have a barrier to working, that they can be reskilled, they can be truly trained, that reasonable adjustments can be made in the workplace. But then also that wider population health approach. As I said, you know, people spend most of their lives at work. It is the opportunity to influence their health and well-being. So it's that workplace environment. I won't go into there, but we pulled out some key areas which we thought we could focus upon, and I'll pick up on these. I'll move on. I'm very much wary of the time, but using those areas, we've developed a set of priorities, and these are short, medium, and long. Many of the challenges are structural. But we also think, particularly on the shorter term ones, what can we do now as a system? As public sector organisations, we are anchor institutions, and there are the opportunities there to do a lot for our workforce. How can we improve the pathways between Department of Work and Pensions, for example, and the health system, so that we have good referrals? How can we develop the existing support systems that are in place that for example, are run by DWP? Many areas co-locate benefit services, for example, with prevention services. Those are the things that we would like to focus on initially, as we feel there's something that we can do. In terms of the skills, and growth strategy. We've worked through these, and Alan, my colleague, will talk to these in a moment, in terms of what's in those strategies that will support this work. What are the things we can move with now? And then moving on to the workplace itself, just pick up that theme of anchor institutions again. There does seem to be, certainly on all the feedback that we had from employers and employees, a hunger for information. There's a sense of frustration that they have a workforce that very often has health issues. They want to do something, so some advice and support would be very much appreciated, and some training. And very much in the spirit of innovation, we think it'd be really good to have an innovation fund whereby which employers could access to kickstart some of this innovative work. So the opportunities, some of them are achievable if they're working differently as a system. Some local investment to engage employers and support innovation. The skills development, very much that is being taken forward by the skills and employment strategy. And there's some structural changes around occupational health services for SMEs. It's something that's being addressed nationally. And then something which picks up on the theme of impact, data. We need to develop a new data set for this work, so it picks up on the opportunities and the synergies across different systems to actually capture the fact that we have had an impact on our workforces. And lastly, it's what's the final phases of the strategy. The final phases of the strategy, I think, in terms of having a strategy that is, I don't think any strategy is ever complete. The world changes, moves on. But in terms of what we've done, we've created so far, we do want to take it out to further consultation. We promised employers that we would go back to them when we've completed the strategy to sense test it with them. And then there's that business case development. And just a list of people who were involved in the development of this strategy to show it was very much truly a representation from all elements of the system. Thank you.
Val, thank you very much indeed. Really helpful and clear. Questions or comments about the approach that Val has set out? Mike.
No, very positive, and I'll take it back within Addenbrooke's, as your anchor institution point and the various elements that we can play there. I think it clearly, as a health provider, we are big employers. So clearly we have an impact on this, and we have an impact on it in the context of the services we provide, because bringing people back to productive life if they've been ill is something that's in our mission. Clearly that mission is extraordinarily challenged at the present time with the backlog, and we're very acutely aware of that. But it's also challenged, and I think it's right to say my number one worry as the chair of Addenbrooke's is the loss of staff. I've now got turnover at healthcare assistants at 20% rising a year. I've now got a 3% increase in departure of nursing staff. It's not by and large focused on worries about Addenbrooke's. It's the trauma of COVID and post-COVID, the worry about the attack on the psychological contract of the ability to provide safe care. It's about the redeployment of people in unfamiliar areas in order to provide patient care. It's compounded now by cost of living and Cambridge being an extraordinarily expensive place to live, and not always a very benign environment in terms of housing and transport. Less than half of my employees live in Cambridge. Many of them are coming 15, 20 miles. They can get cheaper accommodation, cheaper cost of living by working elsewhere. So I think we would be wrong to ignore as a health and wellbeing board that actually the employment of healthcare professionals is profoundly challenged at the present time. So we clearly got to work on that, but I just want realism. That's an important employment factor at the present time. It is my number one worry.
And can I just ask Mike, is there something about the way we take this forward that can more squarely begin to think about some of that context that you've just set out?
I mean, I think, you know, clearly a number of the factors that are involved in the colleagues' report are relevant. You know, the support for people in the hospital, the Nuffield have just published a report a couple of days ago on that kind of thing. And much of that we have been doing and working at, and we will continue at that. I suppose there is an issue about, probably this is more the ICB than this partnership board, but how as a system we try and make sure we work collectively on this. And I know colleagues in district councils, I know colleagues in social care have exactly the same issue. Social care recruitment is profoundly challenging. And again, if we don't address that, that will mean that patients are waiting longer, they wait longer, ergo they're not in productive employment life in the private sector and commercial sector. So I think there is something about how we iterate between this as our ambition for the population of Cambridge and Peterborough, and how that connects into a coherent workforce strategy as health and care providing employers, and how that also then links in to the policies and practices at county and district council level in regard to land use planning, etc. Because I think I really worry about this.
Thank you, Mike. It's really, really important to mention for reasons you said, and both for this strategy, but also, as you say, for specifically for what we're doing with the ICB. I've got Paul and then Jan. Paul?
Yeah, thank you. Just a couple of points. So completely echo Mike's point. I think, you know, it's across the public sector system. They were experiencing pretty profound workforce pressures, but also, you know, across all sectors, you know, private sector as well. The not-for-profit also, in terms of bringing appropriate people in. So I think there's a pressure right across the system. My specific point, Val, is in relation to buy-in from employers. And I think it's fair to say that the success of this strategy will be largely dependent on the extent to which we get buy-in from employers. So specifically, to what extent do we have that? And particularly within SMEs, as they represent a significant percentage of our employment base. And then maybe, Chairman, connected with that point, understanding what the Innovation Fund and associated incentives might look like to try and encourage broader engagement with employers.
Thanks, Paul. I'll just take Jan, then we'll come back to Val. Jan.
Yeah, so again, thank you very much for the paper. It's incredibly interesting. I think my first point was going to be similar to Mike's, which is I think it might be helpful to separate out what we can do as employers and anchor institutions and that programme of work, and link that to structures that we've got in place, like the People Board that is also dealing with similar issues. So I think we should separate out what we're doing as the employers versus what we need to do for employment, if that makes sense. I think that would just be, I think we could get tied in knots if we don't make that distinction. I think my second point is a question around what's the explicit link that's been made between this work and affordable housing, because partly if we've got an employment issue, a lot of that is, and we can't attract more people in, although saying that the census results would show that we're doing quite a good job of attracting people in, but you know, they've got to be able to afford to live somewhere to take on some of these jobs. So how does that link as a question? And thirdly, we spend a lot of money, I would imagine, both as employers and other organisations, on occupational health and employee assistance programmes. I bet if we added up all of the money that was spent on those, it would be a lot of money. And because we all have, every company will have an employee assistance programme. So I just wonder if there is a piece of work to be done which says we're already spending a lot of money on trying to get work environments better, well-being better, retention better, sickness levels down through those agencies. Are we doing an exploration of those to say, is all of that money, how's it helping to this? Because if we think about our pots of money as the only pots of money doing this, I think we may be missing a huge trick.
And I've just got John signalling, so I'll take that. I'll actually Liz wants to come in as well. So do you want to just pick up those first of all, Val?
Yes, I will say something about employers, but then I'll also ask Alan to say something as well in terms of his involvement in this. I think probably we were helped very much by COVID in terms of employer engagement. Certainly that established a lot of links with employers and they were very receptive. I think health had the sort of impact of COVID had really brought home to them in terms of how health impacts on work. And that certainly helped, but also it was very much building on the links through the combined authority and through the district councils. And I don't know, Alan or Jen, would you like to comment on that?
I think you're on mute, Alan. Okay, looks like we're not going to be able to hear him.
I think.
Is that better? Sorry, Chair. Yeah, just to build on the point that Paul raised, Chair. We used a number of different initiatives to engage with SMEs during the pilot. One was using the CPCA business database CRM to about 3,500 businesses. We also amplified it through the business advisory panel. And also we used our contacts like Gemma and others in the local authorities. We had a good response, but one that still needs some further work. And it's one thing that we do need to wrestle with. And it's really about trying to get business to understand the benefits of doing so, because they're very busy people, particularly the smalls and those going up to probably the 49 size. So there is still further work to be had, but we are trying everything we possibly can to work with partners and stakeholders to amplify that message.
Thank you, Alan. Val, anything else you wanted to add at
this
point?
On that point, I think it's an ongoing. I think we'll just have to keep on and work with, because there's some very good networks that we can use. Picking up on Jan's point, I think, yes, we need to link with many other. I think this is always going to be the case. We've captured so much here, but we know that there are other linkages to be made within the system. The affordable housing, I think, is a really good point, because in terms of the lived experience, those are the types of barriers that people experience in terms of, they might be able to get another job, but actually they can't afford to move. And so I think that joining up again is another reason why we do need the whole system engaged. And again, I think there is a lot going on. It comes back again to the stock take. There's an awful lot going on, and it's actually trying to capture that and how we can as a system using that to have the most impact.
Thanks, Val. I've got two more, I think, which probably be our final two, which is John, and then I've got three: John, Liz, and then Nick. So John first.
Thank you, Chair. I think for businesses, I think there's a real important driver in this, which is staff retention, and it's something that's been touched on today. The cost of having a mental health first aider on site or a cycle to work scheme is probably far less than it is to go to agencies and desperately seek new employees to replace ones that have left. So, hopefully in the employer engagement, we can push that it is actually good value for money for them as well to engage in this, and that it might actually help their staff retention too. So, yeah, I think this is really positive.
Thank you, John. Liz?
Thank you. And I welcome this strategy. It will be really helpful in the priority 3 work that Joe Fliss and I are leading on employment and housing. I think there are some clear issues that Jan raised around affordable housing, and I think we need to think particularly about key workers and how we provide more affordable housing for them. The only other thing I'd say is that I'd draw people's attention, particularly perhaps Mayor Dr. Nick, to the Greater Manchester Good Employment Charter. I attended a presentation by them recently, and it was a really good way of giving businesses a reason to start thinking about good employment, and it was a kind of good model.
Yes, and certainly the work they've done on sort of the work and health programme and such things is particularly interesting, I think, isn't it, as other parts of the country. Nick?
Yeah, it's sort of just to follow on. First of all, I would want to acknowledge Alan from
the combined authority and the team, and I'm sure obviously there's a lot of great work. So on this, I'm really, really pleased to see that the combined authority has been kind of working with other partners. It's more of an open question, if maybe people can clarify. We were described in this slide 3 as a pilot site for the development of the work health strategy. So it's a great piece. So once you've had a pilot, and the idea was that we might get some idea from what we do locally, and that will move out nationally. What comes next? Because these were obviously discussions from central government. So is there going to be some money that comes with? I mean, I look, this is the bread and butter of the combined authority, and my thoughts would be, we have funds. We look to small, medium enterprises. We look to businesses to fund them with developing and bringing growth to the area. That's what the devolved authority is about. But if we were to kind of align and saying, look to potential employers and saying, look, what are you doing? How are you aligning with our ideas here? Is there something idea about match funding? So what happens next once we've got the strategy?
Very good question. So Val, Alan, do you want to pick up that point and the others, and then we'll bring this to a close?
There are two things in there in terms of, it was a question that we did ask of the National Work and Health Unit. Well, we've done this. There are a lot of things here that we need support from national level, a lot of structural things. And I think one might say it's work in progress. But I think the what next question locally is absolutely key. And I think as a group, we are committed to continuing to take this work forward. We want to consult, we want to work with partners across the system, but it will depend on the support of the system. There are certain structural changes that we'd like. So the simpler things like making our services more integrated to support people. The wider issues, I think, that could be affected by national leadership around it, on national policy. My understanding is that it's in. A perfect example is occupational health. I think we threw back to them that, well, really, I don't think our local system is going to restructure the occupational health system to provide a system to all small, medium employers. So this would need some national intervention. Something that's being looked at. Certainly, the Department of Work and Health seems to be pushing for it, but I don't know. Alan, I don't know what you have any insight on the discussions we've had with National about it.
If I may, I think there's a couple of things here. One is that we as a team have considered quantifying both the value for businesses, but also putting this into a business case that sort of articulates what the need is and over what period. As you say, Val, that's still in progress. In terms of the combined authority, the mayor officers, we are looking at a small gain share budget for the next 3 years, which can be used for health and wellbeing tools and interventions. We've still got to work that up, but that's a very small step going forward. But there will definitely need to be some national intervention, particularly around funding, if we're to make a difference here going forward. But to what level, I'm not really sure at the moment until we draw those financial equations out yet.
But I think that there is still things as a system which we could have considerable impact. And some of these are brought out in the strategy on how we more effectively integrate our services. For example, we've come back to the anchor institutions, how we can pull in housing and more closely align that to need. So I think, yes, some national intervention along some of these issues would be very helpful, but I think there's certain things we could get on and do rather than wait, in a sense, because at the same time, I think, as was so has been brought up by everyone, is that we have a workforce shortage. We need to use what we've got as much as possible and enable people to get back into the workforce.
Val, Alan, thank you both very much indeed. So we're asked to agree the strategic approach that Val has set out in the presentation, and to go forward with the consultation with partners that has been sketched out, and to note that we'll bring progress back here to this forum, as well as, of course, to the other forums that both Alan and Val have signalled is already going on. Do we agree those recommendations? Thank you very much. Our last, I think, substantive item is the pharmaceutical needs assessment consultation. Can I ask Ian Green, who's the team manager in all policies, to introduce the report? Ian.
Thank you, Chair. I'm very conscious of time, so I'm going to go through the recommendations first, because that will help set the scene and then give you an introduction to the P&A itself. So the P&A is a statutory document that must be produced by each Health and Wellbeing Board, and it must be produced every 3 years and kept on a constant review. So the board is under a legal duty to approve a P&A before October this year. So therefore, the recommendations are asking you to comment on the P&A as it stands currently, as it's up for consultation at the moment. Give a steer on any gaps or changes you'd like to be seen made to the P&A as it currently stands. And most importantly, agree the format of the P&A. The P&A is a responsibility of each Health and Wellbeing Board. Obviously, we now have a combined joint board, so we have the choice of producing one P&A that covers the ICS and Health and Wellbeing Board footprint, or we have the choice of producing two separate P&As, one for Cambridgeshire, one for Peterborough. And I'd like a steer from the board as to the correct direction on that. Then the last bit is to give approval for the final P&A to be approved by the Director of Public Health in consultation with the chairs of the board, rather than bringing it back to another board. The problem we have is, because the board is not meeting until October, we need to have the final P&A produced before October, that's before the board next meets. So I'm therefore asking for delegated approval to approve that via Jyoti and the chairs of the board. So that's the recommendations. But to give you a bit of background, the P&A is a document which should help commissioners. So that will now be the new ICB and Public Health and other commissioners of pharmacy services determine what the need is in their patch, and then commission the appropriate services to meet that need. It's also used by NHS England when they consider applications for new pharmacies to be opened within Cambridgeshire and Peterborough. So our P&A will have a recommendation that either we think we have enough pharmacy provision across our districts, or we don't. If we say we think there is sufficient provision, then it is unlikely that any new pharmacy will open. NHS England will make the decision on whether to open a new pharmacy based on the recommendations contained in our P&A. So currently we've mapped pharmacy provision across Cambridgeshire and Peterborough. We have asked dispensing GPs and community pharmacies their view on the services they provide. If they think there are any gaps, there will be a final report and consultation included later in October as part of the final report. But the indications from the services themselves is that there is enough provision across Cambridgeshire and Peterborough. The P&A is currently out for consultation at the moment. The consultation ends on the 5th of August, and we will collate the responses from the public and feed them into the final version. In terms of the progress on the consultation, we've had just under 200 responses to date, which is about normal for a P&A consultation. What is interesting though, we have significant gaps. So we have good coverage, good responses from the Peterborough area and most of the districts, with the exception of Cambridge City. So we've only had 5 respondents from Cambridge City to the P&A. So there's a separate ask for the partners on the table just to promote the P&A through their comms teams, try and get as many responses as we can as possible. I just want to go through the P&A workshop we held last month. So we held a small workshop with members of the board and other partners to look at the P&A, to look at the content and to come up with errors and gaps. And the main issue there was some more work needed on mapping of services against specific conditions and specific requests to look at mapping opening times and transport. So we've taken those 2 recommendations on board. They will be incorporated into the final P&A that comes to the chair, the Director of Public Health, for approval. The initial work we've done so far indicates that there are some pharmacy gaps in terms of services. So things like smoking cessation services are not always provided in the areas with the highest smoking prevalence. So that's an issue for pharmacies and commissioners to look at. But that's the early indications of that mapping work so far. So I'm happy to take questions either on the P&A itself or on the recommendations as we go through. Thank you, Chair.
Ian, thank you very much. And we'll come back specifically to the question of the sort of 1 or 2 in a second, but general questions or comments for Ian on this paper? Looks like it's people have been represented in the workshop. Just looking around, Susan.
Very good workshop. Thank you. I think we covered a lot on that day. Very good to have the wide representation from across the board that day. Thanks.
Okay, I think implicit in this, Ian, is a sort of view that recommendation that we should have a single response unless people feel strongly to the contrary. So just looking around if anyone wants to, John.
Thank you, Chair. Yeah, it was a really good workshop. And I'm quite happy for there to be a joint P&A because it makes sense with the joint working that's going on already. The only thing I said in the workshop at the time was that if there is something relevant to the P&A that's specific to an area in Cambridgeshire or Peterborough, that we do allow it to be in the document to ensure that it does, you know, it's for the benefit of everyone who sits in that area. And to be honest, I know that would be done in 2 separate reports. I'm sure that can easily be done in 1 report anyway. So I think as long as it's sympathetic to that, where and if it's needed, more than happy.
Ian?
Yeah, I'll come back on that. Yes, we'll do that. Throughout the P&A itself, all the data is by district where we've got it, or by upper tier where we haven't, and then we compare ourselves to East of England at the England average to see any differences. Some of the data is only available at upper tier authority areas, but most of it is district level. So we do, every chart you'll see the 5 districts plus Peterborough.
So I think you have your steer, Ian, that we're going for a single response, but sympathetic to those specific points that John's mentioned. We, I think, are noting the progress on the work, and particularly from the workshop, and in principle approval to the current version and delegating approval for the final version to the Director of Public Health and the chairs of the Health and Wellbeing Board. People happy with those recommendations? Thank you very much indeed. Our last item, I think, really was just forward plan. And Jyoti, I think what we're saying here is that quite a lot of that has fallen out of the nature of the conversation we've had today. We've signalled things that we need to come back to in October, but we are going to give some thought as to whether we can use the October session, in addition to any formal business we have, to have the chance for people to get to know each other in a slightly less formal setting and to do some work in that setting as well. Anything, Jyoti, you want to add to that?
No, just subject to people's availability, of course, but that's the plan, yeah.
Okay. Thank you all very much indeed for coming and for getting us off to the start that we've made. As I say, clearing some ground, as I said at the start, in governance terms, and I think probably giving us a frame of the agenda that we now need to go at. Lots to go at over the coming months and years, but I'm really pleased we got to this point and made a start. So thank you to all of those who've helped prepare us for this. Thank you to all of you for coming, and thank you to those members of the public who've either joined us or who are watching on the live stream. Thank you all very much indeed.